Welcome to This Explainer. We hear these incredible headlines all the time, right? Artificial intelligence diagnosing diseases better than human doctors. But then you actually walk into a hospital, and honestly, the care process looks pretty much exactly the same as it did a decade ago. So today, we're unpacking this really fascinating presentation called The Healthcare AI Gap, Beyond Metrics. We're going to solve the big central mystery. Why do so many beautifully engineered, highly accurate AI models just completely fail when we try to drop them into a real-world hospital environment?
To really wrap our heads around the scale of this gap, you got to hear this staggering number: 68%. Yeah, according to a study published in Nature Biomedical Engineering, 68% of healthcare AI models developed literally never even reach deployment. They just die in the lab. Think about all that funding, all that research poured into medical AI, and nearly 7 out of 10 models never even touch a patient's life. Why is that?
Okay, let's dive into this because this one quote basically holds the entire answer. If the prediction is not followed by action, you save 0 lives. The source data shows us this shocking reality. Less than 5% of deployed AI models actually demonstrate a meaningful change in patient outcomes. You see, predicting a medical event, it has absolutely 0 clinical value if it isn't linked to a real-world intervention. Prediction all by itself is, frankly, completely meaningless.
Section 1. Accuracy versus usefulness, the ultimate AI test. We really need to dismantle this myth that a more accurate AI is somehow automatically a better healthcare tool. Let's break down a real-world sepsis prediction case study to show you what I mean. On side A, we've got an AI model that's 95% accurate. Sounds incredible, right? You'd absolutely want that in your hospital. But here's the catch. It predicts mortality at the exact moment of admission. That means there's literally a 0-hour lead time to do anything about it. Knowing a patient is definitely going to pass away without giving doctors any window to actually change that outcome is totally clinically useless. Now, look at side B over here. This model is only 74% accurate. It actually misses 26% of cases. But the absolute beauty of it is that it predicts sepsis 6 hours before clinical signs, like shock, even show up. And because of that one crucial window, the end result changes completely. That 74% accurate model, it actually reduced patient mortality by 18%. Why? Because the doctors finally had the lead time they desperately needed. They had 6 whole hours to order blood cultures, get IV antibiotics flowing, and prep ICU beds, instead of, scrambling to find a bed at the absolute last second. So, a technically less accurate AI ended up saving way more lives just because it was operationally useful.
And that brings us to the core philosophy of this whole source material. This is honestly the ultimate paradigm shift in medical AI: outcome-action pairing. This is the mandatory link between an AI prediction and a concrete clinical protocol on exactly how to act. Without this protocol, like a literal predefined roadmap for the medical team to follow when the AI sends an alert, the AI has 0 clinical value. It's really just expensive noise. Section 2. The rules for AI success. Making AI work. To actually make artificial intelligence work in a fast-paced hospital, where literally every second counts, we need some foundational ground rules. For instance, put yourself in the shoes of a busy physician for a second. An AI system alerts you that your patient is going to have a massive heart attack in exactly 1 minute. What can you actually do with that? The harsh reality is basically nothing. If an AI gives you a warning without enough lead time to effectively step in, it's functionally useless. Let's map out what proper lead time actually looks like in practice. At T-12 hours, the AI flags a high risk. Okay. At T-6 hours, the medical team acts, and antibiotics are started. T-2 hours, the ICU is booked. So by T-0 hours, when the sepsis actually sets in, the patient is already fully supported. And this brilliantly illustrates how having meaningful lead time directly translates into coordinated, life-saving actions rather than just pure panic. But look, lead time is really only one piece of the puzzle here. We also have to talk about volume. Think about your smartphone for a second. How many random notifications do you get in a day? Now, how many medical alerts do you think a doctor gets in a single day? 350. That is a staggering, very real statistic published in the New England Journal of Medicine. 350 alerts per clinician per single day. Just imagine your screen flashing with potential life or death warnings 350 times a shift. You would inevitably just go numb to it. And actually, that numbness is a highly documented phenomenon. It's called alert fatigue. Because the system is firing off so constantly, 96% of these alerts are simply clicked away or ignored.
only 4% are actually acted upon. It's literally the classic boy who cried wolf scenario, just playing out in our hospitals. The source data points out that because of this severe alert fatigue, a dangerously high 44% of real, critical alerts end up being completely missed by doctors. So a system designed to save patients actively endangers them if it's too noisy. So, what's the fix? How do we build a real solution? Well, let's look at how we design smart alerts that doctors will actually trust. The presentation gives us a great 3-step blueprint. Step 1, raise the threshold. Don't let a totally normal heart rate of 90 trigger a panic alarm. Let the clinical experts set a higher, smarter bar. Step 2, context-aware routing. Don't send a heart attack alert to a dermatologist who's checking on a rash, right? Route it specifically to the exact specialist who can actually act on it. And step 3, actionability check. If doctors are snoozing or overriding an alert more than 40% of the time, the system needs to automatically flag that the AI is being unhelpful and pull it back for reevaluation.
Section 3, Real-World AI Wins. AI in Practice.
So what actually happens when hospitals follow these rules on the ground? Dr. Kamala Avansha from ASU gave this absolutely perfect framing quote. AI is an augmentation, not a replacement for what our physicians do. At ASU, they're successfully using ambient listening AI. Basically, when a doctor talks to a patient, the AI silently listens to the conversation and automatically drafts the clinical notes for them. This directly fights massive clerical burnout, literally giving doctors back the hour and a half that usually spend every single day just typing up patient charts. Then we've got Dr. Kiran Awanch's work at Honor Health, which is this massive system with over 70,000 employees. They partnered with an AI application called Qventus. But here's the cool part. They aren't just using AI to diagnose rare diseases. They're using it as a foundational model to solve gritty operational bottlenecks, predict optimal patient discharge times, and really streamline those incredibly complex hospital workflows. So the crucial point here is really captured in these massive operational wins. By using AI to optimize care progression and flow prioritization, Honor Health saved 50,000 cumulative patient days. They successfully discharged 86% of targeted patients early, which safely frees up vital bed space. And by optimizing their schedules, they managed to fit in 3.3 additional operating room cases every single month. They basically took AI out of the research lab and turned it into an incredibly efficient hospital logistics engine. And man, that operational efficiency translates directly into vast resources. Just by reducing the length of stay using these AI predictions, Honor Health gained an annualized contribution margin of $3.8 million. That is a massive financial impact, and it represents capital that can be reinvested right back into expanding and improving patient care. Section 4, Ethics, Trust, and Guardrails, Deploying AI Safely. Now, before we get a little too carried away with all these amazing financial and operational wins, we really have to ground ourselves for a second. None of this incredible technology matters if it isn't deployed safely. Deploying AI at this scale requires absolute trust from the patient. That means strict HIPAA adherence and robust data encryption to protect privacy. It demands continuous data validation to make sure the algorithms aren't unintentionally skewing results based on demographic factors, because fairness in healthcare AI is just an operational necessity at this point. And perhaps most importantly, we have to treat these models with the exact same scrutiny that we apply to new pharmaceutical drugs, ensuring strict FDA compliance for what's now officially called software as a medical device. Without these guardrails in place, clinical adoption is simply going to fail. Which brings us to our final, somewhat provocative thought. When we look at all these complex models, the predictive alerts, and the automated workflows, it's pretty easy to ask, is AI replacing doctors? Well, based on the data we've explored today, the answer is a resounding no. True clinical AI is all about doing the administrative, analytical, and logistical heavy lifting simply to give human doctors back their time to finally focus completely on you. It's a profound shift in how medicine operates, and we are just at the very beginning of this revolution. Thank you so much for joining me on this explainer, and keep questioning how the future is built.